Go ahead and start. Jen.
Hi, good afternoon, everyone, and welcome to our first seminar of the IHPS Grands Rounds seminar series for the calendar year 2024. I'm very, very glad that all of you can join us in person or on Zoom. Today's topic is adoption and exnovation of patient engagement strategies in U.S. physician practices. And exnovation is sort of a funny, interesting word, but I think we're really curious to hear about that. We hear a lot about adoption, and it's great, I think, to hear about exnovation or unadoption. And so with us to talk about this topic is Dr. Hector Rodriguez, the Kaiser Permanente Endowed Professor of Health Policy and Management and Director of the Center for Healthcare Organizational and Innovation Research and Chair of the Graduate Group in Health Policy at UC Berkeley. And so when he's not wearing all of those hats, he is studying organizational behavior, performance management, and racial ethnic disparities in healthcare. Dr. Rodriguez is a proud Cal alumni of UC San Diego and UC Berkeley. He completed his PhD in health policy with a specialty field in medical sociology at Harvard. And he's authored and co-authored numerous peer-reviewed publications on a variety of healthcare management and organizational behavior topics. He is a member of the National Academy of Medicine and has received numerous other awards. So, and I'm an alumni of the PhD program in which he teaches in at UC Berkeley. So it's a special treat for me to welcome Hector to talk about his research.
Thanks for that kind introduction, Jenna. It's really great to see everyone. I see some familiar faces I've only seen on Zoom before, so it's really great to be here. Thanks for coming. And thanks to all of you who are listening at home. And I welcome feedback. I'm going to try to, I have more than I probably can present, so I may skip a few slides. Please excuse that. I'd love to have 10 minutes of discussion and questions and answers at the end. I'd love to get your feedback on new directions and questions. The last bit I'm going to present is not peer reviewed yet. I'm just in the thick of it, so really love feedback on that. So today, as Janet mentioned, I think I was drawn to this topic of exnovation because of our obsession in healthcare, the healthcare industry, with adopting new things, new innovations, new care models, new technologies, etc. But we really rarely give thought to what needs to be removed in organizations in order to enable the slack and energy to devote to adopting and implementing new innovations and practices. So we rarely think about the other side of adoption. But we know that we're currently in a space in primary care in particular, where we have high levels of professional burnout, staff turnover, and dissatisfaction. And so we really should think of exnovation as potentially an intelligent way to build capacity, to enable capacity for organizations to take on new approaches that may be more effective for patient populations that we're serving. And I'm particularly interested in patient engagement strategies because they're so novel and innovative, and they're accumulating evidence right now in research. And I'll be talking mostly about shared decision-making processes, decision aids, as well as motivational interviewing, training, and supports, and then shared medical appointments as sort of delivery system-oriented patient engagement strategies. I'll touch on some other ones like risk assessments and patient involvement and advisory groups, but my focus is really on the delivery innovations side of things. Foundation for this work is really national surveys of physician organizations. And these, I'm going to share with you studies that span 2 different surveys of national representative samples of primary care physicians, practices with 3 or more primary care physicians practicing in them. So that's the sample frame for these surveys. The first one was done in 2017, and the second one was completed in 2022. So during the COVID pandemic, which gives us the opportunity to look at exnovation in the context of this COVID pandemic and what strategies are retained and what strategies are removed by these practices over time. Today, I wanted to give some basic level setting of innovation and exnovation definitions. I wanted to situate patient engagement strategies and these innovation in the context of broader capabilities of primary care practices and what we know about primary care capabilities and their association with spending and quality. And then I'm going to dig deep into patient engagement strategies, specifically share some evidence about what is organizational factors that are correlated with adoption of patient engagement strategies. What are the role of system influences like larger healthcare system ownership on primary care practice adoption of patient engagement strategies. And then I think an issue that the field is really torn with is how do we implement patient engagement strategies? Do we throw the spaghetti on the wall and see what sticks, try to do everything? Or is there an ordering of patient engagement strategies that is more consistent with retention of these strategies and implementation, effective implementation? And I'm going to talk a bit about this concept of exnovation and a first study that I did a few years back on chronic care management processes, which I see in contrast to patient engagement strategies are much more evidence-based in terms of research evidence, underscoring the benefits of diabetes care management, for example, having nurse care management, having registries, having reminder systems, and those sorts of things. The patient-centered medical home and other models of care have underscored a lot of these interventions as a pathway, as building blocks of improving primary care capabilities. And in contrast, patient engagement strategies, as I mentioned, have accumulating evidence over time, but they're not as tried and true as chronic care management processes, which have lots of care models like patient-centered medical home promoting the adoption of these capabilities. And so I was really interested in patient engagement strategies as an innovative practice with less accumulated research evidence. When we think about innovation, so innovation is the adoption and implementation of a new service, product, process, or technology to an organization. And innovations tend to be significant departures from the way that work was done in the past, and they can often be disruptive to organizations, meaning they can cause a lot of stress on the front line, a lot of uncertainty, a lot of pushback against these innovations because of the ongoing operational needs. Innovation doesn't have to be new to like the industry as a whole, but needs to be new to the organization. And why are we innovating? Like, why would we care about doing things differently? And we're really trying to achieve multiple aims. And many of you have heard of the triple and the quadruple aims of improving quality and patient experience, controlling spending, costs, and improving population health, while not burning out our frontline clinicians and staff in the process. So I think the fourth arm that we've seen in recent policy discussions is the fourth arm being clinician satisfaction and staff satisfaction, work satisfaction. And what we know is that even when an innovation is implemented successfully in one healthcare delivery organization, like I worked for Kaiser for like 7 years before getting my PhD as a management consultant. And so I saw really powerful team-based models of care work well in Kaiser, but not work so well in other organizations when they're implemented. So this is a key issue, that innovations, even when they're found to be effective, don't necessarily naturally diffuse or disseminate in a field. And there may be levers that we can think about to support dissemination of promising interventions, innovations. And in any innovation, this is a typified distribution of organizational innovation. And on the bottom axis, you see time to the adoption of the innovation, and then the distribution of adoption based on that time. So initially you have innovator organizations who are willing to take risks because innovations have high risk of failure. And so you need small, nimble organizations, not the Kaisers, but more like the One Medicals and the Chen Meds, who are going to innovate in this space. And where Kaiser's going to wait to see if those innovations work in these innovators, and they'll be the early adopters that make this implementation of the senior care model, for example, older adult care model, more visible to the field. And then once Kaiser adopts in the early adoption field, then other organizations begin to adopt due to the mimetic pressure, meaning that they're copying what Kaiser does. They're not necessarily looking for evidence of effectiveness, but looking at what other influential organizations are doing. In this way, adoption is a social system, sometimes informed by evidence generation, but a lot of times, most of the time, there's social influences and reputational and mimetic forces that shape adoption. In this model, you could see that the laggards, or those organizations that adopt late, are only about 16% of the distribution. There are some issues, like I would say electronic health record adoption before meaningful use. There would be a high proportion of laggards in this distribution. So this is just a typical distribution, but the idea is that not all organizations adopt at the same time, and there are organizational characteristics associated with different adoption in different phases. What this does not get at is this idea of exnovation. So when we talk about innovation, we've been thinking about when organizations adopt innovations, what are the factors associated with adoption, but we never talk about removal to make room for these things. So exnovation is the removal of innovations, and exnovation can be a result, once implemented, these innovations do not improve organizational performance. So we tried this new model of care for seniors. It didn't work. We had higher no-show rates. We had lower patient experience as a result of that. It doesn't improve organizational performance. We're getting rid of this. 2, it works, but this is too much drama. Like, it required too much coordination and interdependencies, and there were a lot of fumbled handoffs here. And so it just doesn't fit well in the routine of the operation. Similarly, it could not fit well with the organizational strategy or incentives. Like, we're not getting paid to do this part for the patient. And so it will unravel because the incentives aren't there holding it in place. What we see here a lot is in chronic care management in the early years, I was really interested in, like, we were always told even 10 years ago that value-based payment is on the horizon, and we're here 10 years later, and it really hasn't moved that much. And so what happens when these organizations, these early adopters, take on these capabilities in order to meet value-based payment, and it never comes? High likelihood that it may be exnovated or removed from the organizational infrastructure. And in 1981, John Kimberly at Wharton was the first scholar to coin the term exnovation and to describe the removal process at the tail end of the innovation process. And so I wanted to build on some of the theory of disseminating innovations in healthcare to kind of draw out where I see exnovation fitting in. So one is, rule number 1 for dissemination of innovations in healthcare organizations is that you have an organized system of search for innovations, whether that be evidence review, ways of sharing best practices during meetings or grand rounds or other things, but to have those systems in place where you can bring in the information from external organizations. Then within your organizations, once you've decided to implement this new model of care, for example, you find and support the innovators within your organization. So within an organization, there's going to have this distribution of innovators and laggards as well. And you're going to want to find those innovators within your organization, figure out how to support them. And once those innovators have done pilot testing of the intervention, for example, the model of care, you invest in the early adopters, make the early adopter activity very visible by celebrating successes, showcasing the benefits and various communications, so that everybody else in the adoption timeline can understand what the benefits of innovating are. In addition, recognizing and supporting adoption or reinvention. So there may be innovations that need to be adapted to fit in specific contexts, and there may be early adopters and innovators that can serve as mentor roles for individuals and units within your organization that are likely to be laggards, like a mentoring system to help with innovation. 6 is a very important thing, and it's create slack for change. When diffusion of innovation theory was developed, and when Don Berwick kind of summarized this in JAMA like 20 years ago. This idea of creating slack for change means that you just can't continue to pile on innovations on top of each other and expect them to be implemented well, that you have to create slack for change. And what does creating slack for change means is that you have to remove something and stop doing things in order to create that slack. And I wanted to be a little more deliberate about what slack meant, so I have a new rule. 7, which is exnovate technologies, processes that no longer add value to make room for those that do. So I'd like to kind of put this on your mind as like whenever we think about innovation and creating slack for change, exnovation should be something that we think about as we think about creating slack within organizations. Before I dive into exnovation of patient engagement strategies, which is the focus of this talk, I wanted to give you some background information on research that we've done, linking generally physician practice capabilities with Medicare spending. And what we did in this research is we wanted to ask the question, do Medicare beneficiaries that are attributed to physician practices, again, these are primary care practices with 3 or more doctors practicing in them with robust capabilities, meaning, and I'll share with you what that means later, receive higher quality of care and have lower spending compared to patients attributed to practices with relatively limited capabilities. And so the capabilities we're really interested in looking at is the use of evidence-based guidelines for various chronic conditions, electronic health record decision support for various chronic conditions, complex care management programs, so high-risk patient management programs, innovative approaches to delivering patient-centered care, and I'm going to detail what these are here. So innovation capacity, we developed, essentially we had this survey with all of these different capabilities that we assessed, and we could think about a regression model that threw the kitchen sink and every single capability as a predictor, but we realized there's a lot of collinearity between these various capabilities. So we're really interested in seeing if we can reduce the construct to a composite measure that could include all of these capabilities underneath them. So we developed 3 different subdomains: innovation capacity, which included care management programs for complex patients, evidence-based guidelines, electronic health record functions and disease registries. We have management and cultural capacity, which depression care management seem psychometrically to fit with these learning and team culture capabilities, largely because of the boundary spanning nature of depression care management in terms of organizational boundaries spanning different responsible units, and capacity for innovation. And this is the measure that I'm going to talk a lot about. It's organizations' ability to take on new innovations and what are the barriers for these innovations in practice. And then we also have patient-centered care focused activities, which are patient engagement activities, which are shared decision-making, motivational interviewing, and shared medical appointments. We also have the Baldrige criteria. Many of you know the Malcolm Baldrige Award, and the criteria around patient responsiveness were assessed here, as well as the collection of patient-reported outcomes for pain, depression, disability. And so what we did is we linked this survey to Medicare claims data, fee-for-service claims data, and we use an attribution rule consistent with the Medicare Shared Savings Program, which looks at the plurality of primary care visits to attribute patients to practices. And in our sample, you can see after various restrictions of patients with ESRD, who are unlike the other Medicare fee-for-service beneficiaries, and those who are deceased in the calendar year, we have 1.4 million Medicare beneficiaries attributed to 1,772 physician practices within these surveys. And so just to give you a sense of the factor analysis and the resulting distribution of the capabilities, this slide shows you the various capability on the left column. And then you'll see for all practices, the care of complex patients, for example, 39% of the capabilities were adopted for overall. In these robust practices, it was 55%. In mixed practices, kind of in the middle, 35%, and 28% in the limited practice. practices. And as you could see, this pattern is consistent across all the capabilities, suggesting that this factor analysis did distribute the practices to these groups that have shared variation in terms of robust, mixed, and limited. If you look at patient engagement activities there, just to point you there, we see about 35% adoption, but we see a big difference in adoption between robust practices, which have about half of the capabilities that we assessed adopted, and only about a quarter of them adopted in the more limited practices. So these activities, again, are shared decision-making, motivational interviewing, and supports for that, as well as shared medical appointments. And when we look, I wanted to point you to this. One thing that I've learned from other scholars who talked about burnout is one of the challenges of feedback to individual clinicians about their clinical performance. And there's a couple of issues that have kind of surfaced over the last decade in this domain. One is that sample size requirements for reliable estimate of physician performance. So you wouldn't want to grade a physician when their sample sizes for overuse, for example, have a small denominator, and use these for high risk efforts like pay for performance or incentive programs. So I think one of the things I wanted to highlight is that you do see some differences between robust, mixed, and limited practices with respect to their use of feedback on clinician performance, but not as striking as you see these other capabilities that we assess. And I want you to just pay attention to these feedback systems because they'll come up later in the Exnovation discussion.
I have a question. On the prior slide, one more. The robust folks, the mean number of physicians is much larger than all the others. Is the median also that big a differential? I'm guessing it's a very skewed distribution.
Yes, we do see, yes, that's a great point. We do see drastic differences in total physicians. See at the bottom, second to the last row, as well as advanced practice clinicians. Although you could see the more limited practices have a higher advanced practice clinician count. And these are factors we do control for in the multivariable analysis. These are definitely descriptive.
And I think from previous research that you and Steve Shortell and others have done with this, I think that, that's a pretty large body of research that your research and others that would say larger practices tend to have more of these capabilities.
Absolutely.
All other things being equal.
So that doesn't surprise me at all. It's like 10x.
Yes.
At
So
the mean.
potential confounder there.
But then connecting to your next slide about being able to measure physician performance, those are also the same practices because their N is big, where they've got better able to compare against each other because they've got big numbers.
Yeah, that's right. But what I'm surprised about is I don't have the significance levels here. They're all PO 0.001.
Oh yeah.
But here you see in that second to right row, you see not all of them have stars there, suggesting that there's less stark differences on these measures. And you'll see why and when I talk about Exnovation. So when we take these capabilities, robust, mixed, and limited, and then we merge, Medicare claims data to them, and we used 3 different quality measures, which are pretty basic because they're claims-derived measures on mammography screening, A1C testing among diabetics, LDL cholesterol screening among diabetics, and we looked at utilization measures like 30-day readmissions, all cause, hospitalization for an ambulatory care sensitive condition, and an unnecessary ED visit as determined by the New York University's algorithm for identifying these unnecessary ED visits. And we could see there's no adjusted models that account for size and ownership of these practices. We see these capabilities unassociated with any of the outcomes except spending. And we see that mixed and limited have higher total spending compared to robust practices in this model. And just to depict that it's a very small delta. So robust is the green, mixed is the middle bar, and then red is more limited practices. As you could see, this is all Medicare beneficiaries who don't have ESRD. And so we see the costs around $12K per year with a minor difference, about $300 difference per patient per year in robust practices. And so as part of this, looking at capabilities, what we understand is as a collective, we look at these capabilities together, we can tell that robust, mixed, and limited practices have similar quality of care on these measures of quality, which are claims derived, which have that limitation. So there may be differences in other types of measures like patient-reported outcomes, patient experience, et cetera. But we see also that they're able to provide this comparable care at somewhat lower cost and spending compared to these robust and limited practices. And if we take that level of patient savings and apply it to all the eligible Medicare beneficiaries, we would have about 15.1 billion in annual savings on average that could be generated. And one of the questions as we embarked on this research is like, we really wanted a parsimonious predictor of capabilities, but we know patient engagement strategies, while they're part of this robust capabilities measure, may have different relationships because there's less evidence supporting them. So we were really interested in unpacking patient engagement strategies. So this study essentially looks at what are these capabilities associated with broader adoption of patient engagement strategies. And the conceptual model that we used here was that patient engagement strategy characteristics, whether these strategies required a lot of training, whether there was a lot of workflow disruption, whether they required changes in norms or behaviors, whether they were technology dependent, and whether patient participation was required, will all impact the implementability of these engagement strategies. And that market forces like Medicaid revenue and the region, as well as network affiliations like belonging to an accountable care organization, as well as characteristics of the physician organization, so their ownership type, as an example, and practice site characteristics. And these are the large focus of this. We're looking at size, HIT capacity, screening activity for social needs, as well as medical needs, internal dissemination strategies, patient responsiveness, and care management, chronic care management processes. And our hypothesis here is that these, in particular, chronic care management processes will be strongly associated with adoption of patient engagement strategies here, but that we won't necessarily see consistent relationships. And so one of the things that surprised us is in our past work with care management processes, we always saw healthcare system ownership and hospital ownership as being positively associated with chronic care management adoption. Here is the first evidence we have of where systems can hinder innovation. We see here comparing the mean scores, these are out of 100. So taking all of those 20 patient engagement strategies and looking at the percentage essentially that were adopted, we could see that all ownership types do better than a healthcare and hospital system owned organizations. If we were looking at care management process, it would be the exact opposite. Hospital, healthcare system ownership, higher adoption, the rest are lower adoption. So there's something cultural here. And what I kind of my post hoc explanation is that hospitals and healthcare systems pay attention to external incentives, and that's it. If it's not part of this external incentive, there'll be like a really hard sell internally to focus on it. Whereas independent practices and doctor-led organizations like medical groups tend to have more latitude to focus on what they feel is right for the patient and be less constrained by business people and administration potentially.
No, Hector, I'm smiling because I have a student in our Master's of Health Policy and Law who is a former leader in care management in a large system in California, not Kaiser, who has told me essentially the same thing about how her efforts in her system to do some broader adoption in care management and patient engagement got shot down.
Yes. So if it's not being paid for directly, if it's not being incentivized or rewarded, healthcare or health.
And in their case, not in the short term, even when you could say, well, long term, doing this for your diabetic patients would actually save the system money. Well, that's nice, but that's not going to help us next quarter or next year.
Perfect. Yeah, the time horizons of some of these are probably, in terms of linking patient engagement adoption to savings, could be delayed, a lag effect. And what we see here is as we hypothesized, the more that you do in terms of care management for specific chronic conditions and adopt care management, like nurse care managers, registries, reminder systems, et cetera, the more likely you're going to adopt shared decision making, motivational interviewing, and shared medical appointments. And you could see this distribution where at the 75th percentile of the CMP score, care management process score, is associated with 44 out of 100, whereas being at the 25th percentile of the care management process scale is 35. And so we were really interested in what the heck is going on with healthcare systems and constraining innovation. And if we looked at multi-level, if we only took the system-owned practices and did a multi-level analysis of, we also did a system-level survey, which was great in this NCHOS. So we were able to link the system-level survey to the practices that belong to the system. And we were able to look at the system characteristics or things that are system characteristics like the system size or its health information technology capabilities. Is that shaping the adoption or constraining the adoption of chronic care management processes? And so we had to use a more limited set here because of the analysis here. So you'll see the chronic care management processes that we look at, as well as the patient engagement strategies. Just to highlight patient engagement strategies, here we have shared medical appointments for cardiovascular disease, diabetes, motivational interviewing for smoking, for weight loss, for physical activity, for medication adherence, training in motivational interviewing for staff. Decision aids for diabetes, training, routinely use of decision aids, staff training on shared decision making, routine engagement in shared decision making, and follow-up after shared decision making. And so one of the things that came out of this analysis is that we found that there was very little system influence other than health information technology that seemed to be associated with greater practice level adoption, and all the action seems to be at the practice level. So we were interested in this pathways idea too. So in a separate study, we assessed primary care practice use of patient engagement strategies. And we were really interested in this issue is there, if we can use some psychometric methods, which what we use was mock and scale analysis, can we identify a natural ordering and a cross-section of these capabilities in a population of practices? Can we see essentially the mock and scale method that says, if you have this in place, do you also have this in place? And so that with that methodology, you can determine the ordering of adoption and like which is easier to adopt than another capability. You can make that inference there. And so what we did is essentially threw in all of these patient engagement strategies. You can see on the left interpersonal and the right technological patient engagement strategies. And when we tried to order these together as one group, there was no natural ordering that we can identify, meaning that it's chaos. But when we stratified,
Against the wall.
when we stratified, however, based on interpersonal strategies versus technologically intensive strategies, we did find this ordering that you see here. So on the outside is the easiest, quote unquote, and in terms of psychometric methods, it's difficulty, quote unquote, of these items. And so you can see here, there's a path for practices to focus on interpersonal strategies and get through this bundle or move towards implementing this bundle of interventions, and then potentially move on to technological strategies, or the vice versa. Start with technological strategies if they're fit with the organization's kind of priorities, and then move on to the interpersonal and intensive strategies. So the results suggest that there is a natural ordering of adoption of these patient engagement strategies, but crossing interpersonal and technological strategies, it seems to be less common as a path towards building these capabilities. And you can imagine a small independent practice who maybe has strong relationships with their patients may opt, there's a selection effect into interpersonal intensive strategies because they lack the HIT maybe, and they focus on what their strengths are, which are relationships. And so they'll build these capabilities first. Whereas if you're working with a big system who's always used EHRs and incentives and feedback systems, you're probably going to start with the technological strategies and build those capabilities up. So what we see is that we see a departure in our field with two different pathways to building patient engagement strategies, but we don't necessarily see practices doing these both simultaneously in a predictable way. So I was really interested in extending this analysis from the robust capabilities paper to understand if we just looked at patient engagement strategies and instead of looking at all Medicare patients, let's look at Medicare patients that may be really sensitive to patient engagement strategy exposure. So did this study linking the same survey and Shaw's with Medicare claims data for diabetic and cardiovascular disease patients. And what we see here is, unlike the robust capabilities, what we see is a kind of U-shaped relationship. And look at the dollar amounts, they're like double what you saw in the robust capabilities paper. So this is narrowing on more expensive patients for the Medicare program, being diabetic and having CD or CVD. But what you see here, adjusting for all these organizational factors and kind of looking at patient engagement strategies and spending, we could see that low and high patient engagement strategies have higher spending than moderate. And what we did is actually dug deep into the spending categories to see what was driving the spending differences. And what it was is the high patient engagement strategies had more home and community-based services spending. And the low patient engagement strategies had more testing and acute care spending. So both of them had more spending, but for different reasons compared to the moderate patient engagement strategies. So to me, this says patient engagement, adoption, and implementation do not come for free. And you might stimulate the use of increase the use of supportive services for patient engagement. So we shouldn't expect a short run savings by implementing these strategies.
Sorry, could you define when you say high versus low, what is that referring to?
It's the going back to the patient engagement strategies. If you adopted most of these, you would be in the high category. And the way that we did it was we scored them and then we took the top quartile and the bottom quartile and compared it to the medium quartiles. Just to be sure that we're looking at the extremes in relation to the middle group.
So Hector, getting back to where you were, yeah, that's clearly a difference in spending, but yeah, and maybe, and this may well be where you're getting. The next question is, well, what am I getting for that increment, which is really less than 1,000? I mean, the difference between moderate and high, at least in your mean there, is not, I mean, that's less than $500 if my math is right, or around that.
Yeah.
So to me, that says, well, I don't know, if I got substantially better health outcomes, okay, maybe not if I'm like one of these business people into quarterly and yearly, but if I'm thinking more broadly, that's my question. It's like, okay, am I actually getting something for that increment?
Yeah.
If I am getting a lot, I might still do it anyway.
Yeah, unfortunately, we found no quality associations
Okay,
either in
well,
this.
so much for that.
So, and I think probably it's because of the nature of the quality measures we're looking at. They're
Okay.
claims-based measures rather
Yeah.
than like EHR-derived measures of control and things like
Yeah.
So the spending data there, those are the Medicare, that's Medicare spending, right? Which also, I mean, presumably that's then the revenue that the organization is receiving, which is also an interesting incentive problem, right?
Yep.
It's like, so you could implement all the, so from an organization standpoint, if you're in high patient engagement strategies, you got a little bit more than if you were moderate. But if you go to moderate, you actually are now getting less revenue.
I think it all
right?
depends too. Like what's unmeasured here is like the specific value-based payment arrangement that they might.
Well,
be
right,
in,
and then you've got that as a payment incentive
Right.
problem. Yeah.
But but that's a question, Hector, is this spending for the fee-for-service beneficiaries solely in the physician? It is solely in the physician practice, so you're not like.
No, this is all spending across.
All spending.
So they're attributed to
So
a practice.
that's
Okay, so
important.
you
That's an
might-
important difference.
Right, so the practice might actually be getting more money and you're staving off hospitalizations.
And
Yeah.
saving,
Yeah.
and that's saving money, and that might actually be, I mean, although Hector's quality measures aren't showing it, but in theory, that might, or certainly the beneficiary might be happy to spend less time in the hospital. You can't
So
measure it, but it might.
disaggregation might be fun there in
In
all your
terms,
spare time.
Of the various spending buckets.
Yeah,
Oh,
like how much of that's going to physician groups and how much of that is savings on the hospital?
Yeah, we
piece?
have proxies, so we can look at management and evaluation visits, which you can proxy for
Yeah,
that.
because it's like, are you cutting your revenue
Mhm.
in order to save Medicare money, which is, yes, there might be, but these are fee for service.
Right.
Right, so there might be some value-based benefits,
Yeah.
but,
True,
you
yeah,
know.
yeah.
Mhm.
I really have thought about this from the perspective of Medicare and there's.
Right, should Medicare be incentivizing this?
Yeah.
But from a practice adoption standpoint.
But I think it goes against the common rhetoric, which is patient engagement strategies are the magic pill or the new blockbuster drug.
Right. And there may be reasons we should do them that are not saving money.
Right.
Mhm.
Right.
But,
All right, so to my point, I'm sorry it took me so long to get to Exnovation. But we're using the care management process this is the first study looking at Exnovation between 2008 and 13. And just as a reminder, the correlates of care management process adoption were larger size, healthcare and hospital system ownership, in contrast to what we saw with patient engagement strategies, public reporting, pay for performance participation, and expanded health information technology. So the idea is that Exnovation of an innovation in a healthcare organization may be a strategic organizational response to ensure that sufficient time and resources or absorptive capacity is available for adopting alternative innovations. And innovations are also removed because they fail to be normalized in practice, potentially because of demands required and the sustainability. So I said this before, but as a reminder, new innovations are adopted. CMPs in particular, care management processes, may be exnovated because there's new innovations that replace them, like EHRs. Back in the day, care management systems used to be separate from EHRs, and like new updates to EHRs have built these capabilities inside the EHR platforms. So registries are one area that potentially could be exnovated because they're outdated, for example. Some CMPs may be too costly or controversial to retain. The example I gave is individual physician clinical performance measurement. Lots of drama about small sample sizes and reliability. And the other drivers are initiative fatigue. We're just like, we can't take on another, we don't have the capacity. It could be implementation failure. We tried this and it failed, so it doesn't stick. Leadership changes, I've seen this a lot. With a new CEO or medical director coming in, they just want to make their mark and will change something or remove something, or cost-cutting measures. And as I said before, we've been on this long trek for value-based payment that hasn't really materialized. And so really interested, and when we see from 2008 to 2013, we see about half the population are adopting care management processes on net. There's about a third that are exnovating on net, meaning removing, they're getting the number of capabilities they have is smaller, and then about 16% with no change. And this is just to give you a visual depiction. Like overall, we have 4.5 capabilities out of 10 in this study being adopted overall, and then about 6 in the follow-up period. But we see the adopters are gangbusters adopting, and exnovators, those that exnovated, were early adopters who are removing these capabilities over time. So we see two different, if you think about diffusion of innovation, we're seeing 2 waves, 2 cycles of innovation diffusion, with an early adopter exnovating at the same time that the second wave is adopting those same strategies. And so what is happening here? So if you look at the data, I think I may have just replicated the slide. So if you look at the data here, what capabilities of this care management bundle are they removing? And what we could see is quality of care data feedback to physicians. Like I said, about 1/3 of practices or more of those that are removing capabilities on net are removing these feedback systems, and patient reminder systems tend to be removed over time more than other capabilities. Nurse care management is one of the most durable capabilities that is not removed. And this surprised me because it's probably the most costly capability, but you could see that it is less likely to be exnovated compared to the other care management capabilities. And when we look at what predicts extent of exnovation? We really put forth ownership as a potential, the Medicaid revenue, whether you have high Medicaid or not, and HIT functionality. And what we see here is that higher Medicaid revenue at baseline is associated with much higher risk of exnovation of care management processes, as does changes in health information technology, which safeguards care management processes. The more HIT that you implement, the more that you retain care management processes and less likely to exnovate. So what we see here is it's really common, like a third of the population is exnovating on net, that there seem to be different cycles of diffusion going on here, that expanded HIT reduces the risk of exnovation, and that Medicaid revenue, if you have higher Medicaid revenue, you're going to reduce that over time. So now, moving into 2022, I'm taking these survey, and now with a new survey, looking at the NSHAWS 1 and NSHAWS 2. And we, unfortunately, during COVID, many of you who do survey research realize that response rates are much tougher. So we got about a 38% response rate compared to the 47% that we had in NSHAWS 1. And we threw money at it as much as we could. It just didn't work. So, after excluding duplicates, we have about 1,252 practices. And we have a cohort of practices, that 714 that are repeated in both periods. So I'm focusing on the cohort here. And this is in 2017 versus 2022, so hot off the press-ish. I've ordered these patient engagement strategies based on their level of exnovation. So you'll see on the left side is the one that was removed the most over time, as suggested by the orange bar. And this is over 1/3 of practices overall getting rid of this between 2017 and 2022, which is the use of patient experience measures for quality improvement. I am so sad. I began my career analyzing patient experience and the importance of them, but it seems it's expensive to do patient experience surveys. They tend to have high ceiling effects, meaning that patients generally say great things about their care. And so we see, in the context of all the competing demands, this using patient experience data for quality improvement has fallen by the wayside in these practices. We also see decision aids for knee replacement, knee joint replacement being exnovated. More often, motivational interviewing training for clinicians. This could be because there's a one-time intervention that doesn't get repeated. And the rest are, around 10% or less. The least exnovated is patient-reported outcomes related to depression and decision aids for diabetes. We do see massive adoption of patient-reported outcomes here, though, over time, for diabetic patients, for patients with musculoskeletal, and disability PROs in particular. And if we look on aggregate at these patterns, what we see is that there's a little bit increase from a 4.2 to 4.8, and this is statistically significant level of adoption overall, but we see the same pattern of, as we saw with care management processes, where we see the adopters really going gangbusters, doubling essentially their capabilities in patient engagement. And we see the exnovators reducing their use of patient engagement strategies on that by about 2 capabilities.
Well, it also seems like the majority of your respondents are either adopters or exnovators. I mean, your maintenance group is 13%. So
we had about 17% in the care management process compared to this 13. So we're seeing much more, 46% exnovation of these patient engagement strategies. Our 46% of practices are exnovating these patient engagement strategies on net, but the adopters are really going gangbusters. So the average is increasing. The other really interesting thing, and this saddened me, is the exnovators, 58% or 60% of them are FQHCs, when only about a third of them are FQHCs as a population. So we see drastic overrepresentation of FQHCs. And we see the adopters being more independent practices. In contrast to what we saw with care management processes, we see that the adopters still tend to be the independents and not the healthcare system and hospital-owned groups. So we had a chance to look at multiple predictors and capabilities associated with patient engagement strategy, Exnovation. And I just wanted to share one key predictor that we hypothesized during the pandemic would decrease is the cultural orientation to innovation of organizations. So on these questions, which are very strongly agree compared to not in each period, we have about 71% of respondents endorsing being in a practice that's open to sharing the failures compared to 55%. So the COVID pandemic was associated with these decrements to these respondents' assessments of their practice culture. So encouragement of new ideas, innovations are publicized, strong sense of belonging, considering ourselves to be a training ground for patient engagement, feeling safe raising concerns, and protected time. All of these were significantly lower in 2022. We also see a key predictor here being ACO contracts, value-based payment. If you're getting more of them over time, expanding them to Medicare, Medicaid, commercial, for example, and innovation culture. What do we see for these different groups? Overall, we see this change in innovation culture down during the 2022, but we see increases in ACO contracts by about a half a contract in the population. But what's really interesting is that those practices that are adopting patient engagement strategies are actually improving their culture over time and reducing their value-based payment contracts, where we see the exnovators are taking on value-based contracts and their culture is compromised. I'm not saying this is a causal relationship, but they're going in different directions. Those exnovators are experiencing major changes in culture in the context of the pandemic, but are also aggressively pursuing value-based payment contracts through ACO arrangements too.
So maybe they're pursuing Slack.
Oh, using the value-based payment to try to address the
Well, or
culture
the,
problem.
you know, they're exnovating because they are pursuing ACO engagement and know that they're gonna have to change other stuff. So they're like, get rid of the crap that isn't working because we're gonna have to be ready for, we need to do other things for ACO, right?
Right.
You know,
That's a great counter explanation.
that it-
So
you have
they're
to do
bringing
qualitative work. to
they're
figure
sort of
that out.
into the fore value-based payment, which
Right.
we know is associated with removal. Okay, that's really a great point.
Mhm.
So sorry for this busy slide, but I was interested in, like, are they just different sides of the same coin, adoption and exnovation? And they're not. We see changes in practice culture being strongly associated with adoption and exnovation. We see changes in IT functionality, however, being much stronger in the opposite direction of what we see CMPs. We see when you increase your HIT functionalities, you're likely to have less likely to be an adopter of a net adopter of patient engagement strategies, essentially. And you see the exnovators there. If you're in HIT functionality increases are associated with exnovation. So we see the opposite relationship where we see CMPs being care management processes and health IT being complementary. We see sort of they're at odds for patient engagement strategies, where we see expansion of HIT not having the same effect. ACO contracts have a small effect here. But to depict this culture, which I think is the strongest relationship here, you could see that this is the change in practice culture. So if you're changing on this scale, you could see the error bars really increase at the tails because few practices had that big change in culture. But if you could see exnovation of PES goes up with more negative changes, reductions in the practice culture. But what we see is it's stronger for adoption. So cultural changes in the positive direction are more strongly associated with patient engagement adoption than decreases in patient engagement are associated with exnovation. So just looking at the curves here. So we were wondering, what is this FQHC thing and why was it significant, such starkly significant and unadjusted analysis? And when we see here, we see that it's not really associated with exnovation, and no practice ownership is really associated with exnovation in this model. And so we really just wanted to unpack that a little. And what we're seeing is that FQHCs have the largest decrement in practice culture, which is consistent with the other things. And we see solo practices, and you may be wondering, why do these even show up in this survey? Is because when we do the sample frame, there are many practices that lose doctors over time. So we're able to identify solo practices on our data and see that the cultural decrements are happening in these smaller practices compared to other practices. And we could see changes in health information technology are not associated with this. So in summary, increased practice adoption of patient engagement strategies, even with the COVID-19 pandemic occurring. Nearly half of practices exnovated these strategies on net, however, and exnovation of patient experience data for quality improvement, decision aids for knee replacement, motivational interviewing training were the most exnovated patient engagement strategies of the strategies we assessed. As I said before, these are not comprehensive. We didn't assess patient advisory committees or other ways patients can engage with the healthcare system. Cultural orientations to innovation declined, particularly for FQHCs, which is a major policy issue. And declines in practice innovation culture were most strongly associated with exnovation patient engagement strategies, rather than these capabilities like HIT. And patient engagement strategies are exnovated with health information technologies expand in contrast to care management processes. And thinking about Slack, I'm going to end on this. I've been wondering some of the basic ways to create Slack in organizations, and one is through staffing. And the more that we can support primary care clinicians with medical assistants and have a robust ratio, the more that we can support doctors from taking on these patient engagement strategies and clinics taking on these strategies. So to create Slack, we really were interested in this NSHAWS 2 survey. What characteristics of practices, including these capabilities, were associated with having 2 or more medical assistants per primary care clinician. And the strongest predictors, again, are independent and medical group-owned practices in contrast to system-owned practices. So again, for medical assistant staffing and patient engagement strategy adoption, independents and physician-led organizations are doing this more than healthcare system-owned practices. And so as we see more and more system ownership of physician practices, this really speaks to the lack of slack in these organizations, as well as the constraints that the healthcare systems potentially put on the practices with regard to innovation. So my next steps in this are to understand more in nuance when exnovation versus innovation improve versus impede these outcomes. And specifically around FQHCs, given what we've seen here and high Medicaid practices, doing research how to encourage and manage innovations in these settings, given the drastic changes we've seen over time. Thanks so much for paying attention, and apologies for going over with not leaving enough time for questions.
I think we've got a couple minutes, so are there questions? I mean, I know we got folks in the room, but I also want to just check, Kat, do we have questions? No, nothing on Zoom?
No, not on Zoom yet.
Okay, go for it, Lauren.
I was really struck by the slide you showed that the change between 2017 and 22 in the culture of innovation within the organization. I'm wondering if you think that might have something to do with like the larger political climate and polarization in our country, and people being kind of like worried and anxious about sharing their opinions.
So work insecurity kind of things, like I'm not going to take issue with outdated things in the practice right now.
Yeah, exactly.
One of the things that strikes me, and I haven't put this under peer review, but I'm waiting for the comments, because as an organizational researcher, cultural assessments are multiple informant assessments that are generally average. And so that and these are respondents are leaders of their organizations or key clinicians. So we're having this, halo effect anyway on these measures, but even with that caveat, we still see decrements from that rosy colored perspective. But if I were to do a study, it would be very expensive to take all of these practices and do cultural assessments of their staff and clinicians and use those. I think that would be more reliable. But I'm really surprised how this innovation culture, even though it's single informant in kind of a small, let's seven-item measure is really predictive of these exnovation. I thought they would be like HIT or other capabilities, really, but I think it speaks to the idea that patient engagement strategies aren't necessarily tried and true yet, and they're more on the innovative side, and so these innovation capabilities are going to be really strongly associated with doing these innovative things. Yes, Alicia.
Thank you so much for this talk. It's really interesting. I'm an anthropologist, so thinking about culture in like the survey sense is really interesting to me. And I'm curious, like what, like where kind of clinician values and kind of personality champions, like things like that, that obviously shift as practice, you know, people change positions and things like that. But the things that I think of that kind of constitute the culture of a practice also that might influence this, you know, if you have someone who's like really excited about or did a, you know, their personal experience, did a rotation and, you know, that really tapped into innovation at one point in their training. How do you incorporate those types of
Like individual actions,
but like thinking about that then maybe at the
Yeah.
kind of aggregate level of like, you know, those roles in a practice or the values in a practice that are sort of like a little bit more hard to capture, I
Yeah.
guess.
Boy, that's tough to get on a survey, right? Survey reported information on that. I will say that I'm a little biased in my views of culture, being an organizational researcher. The one that we drew these survey items from is through the competing values framework, which is sort of like a ipsative measure. Have you heard of these measures? Like they're essentially like they force you to be in one quadrant or the other. Like you can't be two things at the same time. Certain. And so through assessment of these competing values questions, they assess how hierarchical is the culture, how entrepreneurial is the culture, risk-taking. And the risk-taking stuff is mostly in this set of items. But we also have team-based culture and then the rational culture and measurement culture. And so the way that that measure, it tries to assess which box or quadrant the organizational culture is and how strong are their tendencies towards the specific culture. I am sort of torn because it has its appeal in being parsimonious and simple to communicate, but I think you have a really good insights. I think that there's these other, depending on the actors and their actions and the infrastructure, like disseminating evidence as a structure that could enable this, weren't really assessed in this measure. We did assess whether dissemination strategies, so like are using meetings or newsletters or these sorts of things to disseminate information as well. But we consider them outside of this cultural measure. Thanks for that.
Interesting.
Thank you for your great questions, and I'm happy to chat offline also. hrod@berkeley.edu. Thanks for your attention.
Thank you.